Good morning, everyone. I hope everyone's doing great. My name is Sunny Sharan, and I'm the chair for this virtual conference. I'm super excited today to welcome you all to today's event on behalf of our awesome organizing team for this virtual event. As we missed last year's event due to the pandemic, and I'm sure all of you faced extremely challenging situations over the past year. And as we try to find our way into the new normal, we thought we'd select the topic for today's event as adapting to change from surviving to thriving. As the topic suggests, the focus of this virtual event is to help us visualize how the new normal is going to be like professionally in health IT. This year's organizing committee for this event, as you can see their pictures on the slide, I really want to thank them, give a shout out to all of them in the beginning and also at the end. It's been hectic for everyone and everyone's traveling with all their schedules. They've been able to pull together a diverse set of thought leaders from various segments of healthcare, from government to payers to technology leaders to clinical leaders and to academic leaders. We hope you'll find this event valuable, and we encourage you to engage in this conversation by asking questions. As you can see, there's a Q&A option there. You can type in your questions. Please engage in the conversation today. I'll kind of give you an overview of the agenda today. We have a keynote and 5 panels. There are a couple of breaks, one at 10 o'clock, 10:05, and later at 11:40. So these are short breaks, 11:55, I'm sorry. These are short breaks. Feel free to take off and come back in. And just to orient you the way this agenda was laid out, we have a keynote from government stakeholder, and then we have a payer panel, which is like, we have like really led by Sajid and 3 CEOs of the major health plans in Southern California. And then we have a technology panel. We have 2 technology panels today. The morning technology, earlier in the day technology panel is about tech companies and how they're looking forward to investing into health IT, or making progress in health IT. And the second technology panel that's towards the end of the day is about enterprise health IT. You have representation from DHCS and UCI Health and from other awesome organizations. We also have 2 workforce panels, one on clinical workforce and another for internships and job seekers and opportunities for someone who's just getting out of college or who wants to go back to school and find opportunities to enhance their learning. So the content's great. We hope it'll be useful for everyone. Please engage in the conversation. With that, I have a few housekeeping rules. So few things. All the attendees will be in listen-only mode, and please post your questions in the Q&A panel as the picture shows on the screen. And recordings will be available afterwards. If you have trouble getting into the conference virtual event, please email socal.info@himschapter.org if you need assistance. Again, the email address is socal.info@himschapter.org if you need assistance. With that, I would like to pass on the proceedings to someone who's primarily responsible for today's event, our Southern California HIMSS chapter president, Jerry Pavia. Many of you know Jerry through her several roles at Southern California HIMSS. She's actually a true leader. She's kept the whole group motivated. And when we started off this event, we just wanted to do a 1-hour event. Jerry was particularly interested in doing a full event, and we've been able to put together this event primarily to Jerry. A couple of things about Jerry. She's been on the board of HIMSS for over 8 years. She served as president of program, VP of programs, and chaired several successful events. Jerry is passionate about helping business leaders connect with technology to enact positive change. With that brief intro, I would like to request Jerry to take over the proceedings. Jerry.
Hi, everyone. I wanted to say Hello to everyone out there, and on behalf of everyone here at Southern California HIMSS chapter, I wanted to personally thank you for joining us today. Thank you to our wonderful sponsors, our moderators, our speakers, our membership. We could not have made today happen without you. Our committee was fabulous, just like, Sunny, just want to reiterate everybody that you saw up on the screen earlier. And as we reflect on what we have all worked through this past year, the impact it has had on our communities and our families. We have come to a place in Southern California that we feel like there's so much hope. Though we miss seeing all of you in person, thankfully we get to gather here virtually and bring forth a truly wonderful program. Hopefully it'll be education and a truly good educational experience while hearing from some of our very thoughtful healthcare leadership that has joined us today. Today, I wanted to say thank you to our members. Your unwavering loyalty has truly made a difference in our mission to deliver today's HIT conference. We look forward to continuing to work with all of you, hear from you, and while together we will continue to thrive into the next chapter of healthcare. Please join me. It's my pleasure to introduce our keynote speaker, Dr. Jennifer Sullivan. She is the Secretary of the Indiana Family and Social Services Administration. She has served as the Deputy Health Commissioner and Director for Health Outcomes at the Indiana State Department of Health. Join me at welcoming her today.
Good morning, everyone. I'm Dr. Jennifer Sullivan. I'm the Secretary of the Indiana Family and Social Services Administration, and I'm really excited to join you today to kick off the series of conversations that you are having about surviving and thriving post-pandemic. Today, we have some really exciting things to talk about in the experience that we've had in Indiana and the pandemic response. And we're specifically going to talk about telehealth for communities and how to connect social drivers of health to healthcare. I'm really excited to share our experience with you because I believe this has been a shared experience over the last several months. Today, we're going to go through a few topics. First, we're going to talk through the Indiana case study. First, our experience with telehealth, and second, our experience with human services and how those two things have the possibility of blending together to really create a robust experience for patients, as we call them in healthcare, members, as we call them in human services, and just our friends and neighbors and loved ones as we move into the recovery process. We're then going to talk about how to connect the health and human services portfolios using a blended digital platform that I think will start to spur some conversations in your upcoming sessions and plenary groups. And then I want to talk to you a little bit about how we might design a system to thrive. So in Indiana, as in every state, back a year and a half ago in March, we had a shutdown. And in that shutdown, we had to do things really quickly to preserve what we really think is our true north, which is to make sure that we continue access to services, that we enhance access to services, and that we create new services to improve health for our populations. So the state declared a public health emergency back in March of 2020. And under executive order through our governor and through the opportunities that are allowed within our human services agency, we allowed for everything in telehealth to turn on. We literally did it in 3 days. And so we changed from a almost completely full in-person healthcare system to a completely not in-person healthcare system in 3 days. We waived every regulatory requirement possible. So all of the privacy platforms went away. The difference between having audio only and a visual requirement also waived. We waived everyone who was eligible to participate in telehealth. So you didn't necessarily have to be just a doctor or an advanced practice nurse. This included physical therapy, occupational therapy, our developmental therapy program called First Steps for Birth to 3, and really brought everyone into the space of figuring out how to deliver healthcare to people outside of your typical walls of medicine. So this really, on the other end, so now in May of 2021, this became a 16-month natural experiment on rapid cycle launch of a completely new platform for healthcare delivery. And so what I'd like to share with you today is some stories and some data around what that looks like and how we might learn from it to build our platform for the future. Now, that's the first part of the experiment. The second part of the experiment was how to use human services delivery in the same way. So again, same thing occurred, went fully remote in March. Everything in the state had to convert from what was really reliant on in-person interactions. So to get access to SNAP, Supplemental Nutrition Assistance Program, or what used to be called food stamps, you have to come in and interview for that process and turn in documents to, hand them over physically to a person for that application to be complete. We, again, in that same period of time, went fully remote for all of those services. SNAP applications, Medicaid applications, TANF applications, Child Care Development Fund applications, vocational rehabilitative services where we did assessments for whether you need home environments to be able to work or thrive if you have a disability, fully converted to remote in just under a week. And those remained fully remote for about 4 months. What we learned from that is that you don't have to be in person to get human services done. And you also don't have to be in person to get human services done well. So in that process of fully remote, in summer of 2020, we moved into a hybrid model. So we had some skeleton crews present in person so that we would make sure not to enhance disparities in access to services. We really, again, had this parallel natural experiment happening. So healthcare is now becoming hybrid, opening up of services in person and still having the telehealth option available under governor executive order, and the same thing under human services as well. We also really implemented every single administrative waiver we possibly could to make access to our big 3 eligibility programs available to everyone throughout the pandemic. What happened at the same time is that we integrated the Indiana 211 system fully into our Health and Human Services Agency in July of 2020. What that means is that 211, which is a statewide platform, it's a call center of community navigators that help individuals who need services by having someone on the other end of the phone with a database right in front of them that if you need food, if you need transportation, if your energy is about to be turned off, your lights are about to shut off, or your water is about to shut off, or you can't pay your rent, the folks at 211 have a database that they have at their fingertips that can connect you to those things. So think about, as these things are unfolding in parallel, we're watching the data roll in, and we're making decisions about how to help people in the moment. How does this really drive what we can do in this post-pandemic experience from what we've learned? At the same time, we also made our Health and Wellbeing Atlas public-facing in June of 2020 so that we could see where unmet needs were occurring across the state. The Health and Wellbeing Atlas is a really unique database of every individual who applies for SNAP, TANF, or Medicaid in the state of Indiana has the option at the end of their application to fill out 10 social drivers of health questions. Those are things like, have you been thinking about how you're going to pay for food? Are you looking for work? Are you interested in going back to school? Do you feel unsafe at home? Those types of unmet social needs. And if they fill out those 10 questions, we add them to our Health and Wellbeing Atlas and we geocode them to the application site. We now have over 500,000 data points to this Health and Wellbeing Atlas. So in real time, every week when it is refreshed, we can see where things are happening and what people need. This has been incredibly helpful to us across the pandemic time that we needed to keep some services open a little bit longer. rental assistance needed to stay in place as we were still getting tons of calls in 211 for housing assistance, and seeing those unmet needs in our health and well-being atlas as well. And so this integration of people and data and telehealth, not just in healthcare, but in health more broadly, puts us in a really unique space to understand people in a way that we've never been able to do that before. And so as we start to emerge, now we're still in pandemic mode in a lot of ways, but as we start to emerge, we have to think about what are the things that we should keep really forever, and do these two things really need to be separate all the time? We talk about all the time in the social determinants of health science and data that 20% of our health outcomes have to do with clinical care. The typical go to your doctor, get a diagnosis, get a medication, or get a treatment. But the other 80% are all of those human services: housing, food, transportation, safety, climate, air quality, well-being, getting over stigma. All of those things are really the important things that really can launch us forward. And how can we bring them together? And how do we not leave these digital platforms behind, but actually enhance them to make people's lives better? And so this brings us to, our FSSA path, which we've been on since 2017, about making social determinants of health and health outcomes our entire driver for everything that lives within our agency, whether that be mental health or childcare or healthcare coverage through Medicaid and everything in between. And we really start with understanding. We start with that data set that not only is claims data through healthcare, but it's that health and well-being atlas. It's the call center data from 211 that says, hey, we've got a new unmet need that's popping up in this area. Let's go figure out what that is with the community and make some changes. And then really moving into education around what does all of this mean, and how, when someone applies for SNAP, how can we use that as a marker for what else they might need, and how we fill those unmet needs and bolster folks with that back to 8th grade when we talked about Maslow's hierarchy of needs. It's really hard to become self-actualized if you're hungry. It's not impossible, but it's harder. So how do we fill your tummy so that then you can fill your soul? And that education process is really critical for our team and for the community at large to understand where those unmet needs are and how we can help. Once we get there, we understand our data of where unmet needs are happening. We think about what the person is behind them, the community is behind those unmet needs. Then we get to start building a referral network. That was where our 211 integration came in. And that's what we're really here to talk about today, is how do we take that to the next level so that we can build, and our systems and our policies that underlie that referral network, that closed loop communication, move us then to really the ultimate path that we want to be in, and that's in prevention. So that those unmet needs don't happen in the first place, that we've built healthy communities around prevention and mitigation as we move into recovery. That, this path started before the pandemic, but the pandemic really launched it forward and amplified the need to do this work. So in FSSA, this is our symbol for the Health is More Than You Realize campaign. It's the idea that using this blended human services digital platform, we have a heart. And the heart is around connecting people to those unmet needs in a place that helps move them forward: food, education, employment, childcare, housing, stigma reduction, elimination of bias, creation of safety, connection to transportation, and a feeling of belonging. And this health is more than you realize doesn't seem like it is a data and technology driver, but it really is. The connections are all there. And we can't do it without these things being connected in a tangible way. And so let me walk you through what I think that this looks like, certainly as our case study in Indiana has shown, but how we might do it for the future. So first of all, I think about how we have this system in place that really is that 80% social drivers of health connection to health outcomes. That happens with a connection between our 211 system and our Indiana Community Connect, which is the the skin that helps people over the top of the application system really understand what they might be able to access when they're really not sure what it is at all that they need. And then that intersects with a referral database, and that may be one of many. I know in California, where many of you are watching today, the Kaiser system is using a network called Unite Us. There are many others in that same system. Aunt Bertha is another. But that referral database that happens within healthcare systems, that might happen in the community-based organization network, that has to plug in to the networks that happen at the state level, so that state-based eligibility programs, federal-based eligibility programs, and the community who are doing incredible things on a different scale, but with a real local flavor, can start to talk back and forth. So that My Indiana 211 database, if you happen to be a community-based organization and you update your information in Aunt Bertha or Unite Us, that it automatically gets updated so that we all have correct and timely information to connect people to those needs. And so that's when that referral loop between 211, the referral database, and the community-based organization network really gets robust. And we're doing that closed loop referral so that people, wherever they identify those unmet needs, whether it's at the time of a Medicaid application or walking into a food pantry, they can find their way very quickly into meeting those unmet needs so that they can move on to the next thing quickly. Now, phase two, after that happens, I think is when we really get to do the hard stuff that's really intriguing and interesting, which is, let's bring these two things together in phase two so that 20% of clinical care that drives health outcomes is part of the network as well. And so we have in Indiana a statewide information exchange, the Indiana Health Information Exchange. And so the idea that could be, and never has been before, part of this network, that we have human services, healthcare delivery, and communities all surrounding. There's a reason that I have people in the middle, is that really is the driver for all of this, is that they're connecting people wherever they present, whether they're presenting at the top right to a community-based organization, at the bottom right to the health care system writ large, where all of their clinical work lives, or they're just calling 211 because they're not sure where else to go. All of these things integrate together so that we're driving health outcomes forward. So this blended platform is really the idea that we can create a menu of service delivery. It's the idea that it doesn't have to be one. It's not or. It's not Aunt Bertha or Health Information Exchange or Unite Us or 211. It's all. And that there's an integration and a standard streamlined service between healthcare and human services and back and forth. It also allows us to avoid something that I've really been intrigued as I look at the data and literature around what we've seen in this natural experiment in telehealth, something called designed inequity. It's the concept that when we launch something new this quickly, 72 hours to turn on telehealth across the entire state, that if you don't go back and look at the gaps, that you're going to find something that organically doesn't work. And what that means is that we actually are just helping the folks that would have been okay already. And so the telehealth services are delivered to people who already have access to services. And we've seen this in our Indiana data already, that our disparity of the individuals who are accessing telehealth in minority populations is actually greater than the in-person services that we were seeing pre-pandemic. So for example, in our Medicaid population, about 20% of our Medicaid population are Black, and only about 12% of that Medicaid population is accessing telehealth. So there's a huge gap between populations of individuals that are accessing. That's designed inequity. And now we have to go back together and we have to fix it. And it's really important. We also need to support states and members with access and equipment so that this blended platform actually works. It won't work if we don't have statewide broadband. It won't work if our members or healthcare providers or community-based organizations don't have platforms that actually allow them to access these networks. So we have a real call to action here for access at the the hardware level, at the software level, at the data literacy and digital health literacy level for our members, and then also for high quality broadband across states to make this work. So as we move toward the close of our conversation today, I do have a couple of thoughts because I know that you're going to spend the rest of the day thinking about moving from where we've been for the last 16 months, which is surviving, and how we take these things we've learned and move into the thriving space where the parts that worked, we just do those forever as our new model of health and human services delivery. And the things that didn't work, we can throw those out and move back to the way that we did them before. And it's really going to take all of us having these thoughtful conversations together to get that done. So first of all, it's hard to talk about any of this without talking about how do we pay for it. And certainly within the Medicaid space, which is where I think about this, and then of course, across our human services portfolio, we have to pay for the infrastructure in the startup. It requires people, it requires stuff, and it requires expertise. And so we will need to pay for things differently than we have in the past. We can't just pay for services. We actually need to pay for the stuff as well. And so that's where I think bundled payments will be important for us to incentivize creativity. How can we bundle a telehealth payment for a physician office to make sure that all of the folks that want to access it have maybe a mobile hotspot as we get broadband expansion across the country? How can we enable smartphone delivery, or maybe even paying for data access or time, or delivering a laptop for an individual with a chronic disease that's going to need to upload data for mobile device monitoring over time? I think this is the future of how bundled payments work, not just in healthcare, but also in human services delivery as well. As we think about how community health workers can do their work a little bit differently, how case managers can implement this really neat hybrid model of how to bundle this work together, we'll have to pay for it at the state level and at the federal level in a way that resonates with members and also with providers. We also going to need to think about payer parity in the regulatory space. So the innovations that I make and that other states make in the Medicaid space also need to be reflected in the Medicare space and in the private pay space so that we don't have winners and losers in telehealth and telehuman services. And so regulatory alignment across payers will be a huge conversation over the next 12 to 24 months. I'll give you a quick example. In Medicare, you actually can't generate currently a telehealth payment from home as a billing space, whereas in Medicaid, I can. So people actually have to go somewhere that is a allowable billable space within Medicare, whereas in Medicaid, I can pay for telehealth that when patients are in their house. We'll need to really level that playing field across all of our payers. We also need to look at outcome data. What I have flowing in right now is 16 months of claims, and that's a great start. I need to see what people are using and where they're using it from. I'll tell you, across the board, the largest newcomer to the telehealth space is behavioral health. Mental health access has grown by leaps and bounds by opening up the telehealth space for these types of providers. It is a huge win for teenagers in particular who interact with their phones just like they're a person, and really has increased the show rate and the follow-up rate for mental health. But what we need to see next is not just access, but is it working? Are we seeing improved health outcomes in chronic disease, in specialty care, in mental health outcomes? And that data, I think, is beholden on us as states and as healthcare providers to demonstrate what are the things that are working and what are the things that we really need to bring people back into the office to establish that trust and relationship with their provider. And also in the human services space, how do we need to interact with people in a way that makes them feel comfortable that those outcomes are really being met? Do people actually get food when that closed loop referral is made? Do they actually get access to transportation for their mental health appointments? Are we getting housing assistance to the right people in the right place at the right time? And so building those things that we need to measure to keep ourselves accountable within this new blended model and this added menu of options in the telehealth space are really important. We also need to acknowledge that we are going to have a complex workflow in the day-to-day work in healthcare. We can't just add telehealth without training and without support and without technical expertise to a group of folks who are already burned out. We're in a crisis in the healthcare workforce, and so we need to acknowledge that in the way that we design and pay for workflow. And speaking of workflow and a burned out workforce, teleservices in health and human services need to acknowledge that this can't just be another thing that we're asked to do. It has to be a supplement, and it actually needs to take the place of some of the other things that we do so that we really have enhanced services, not only for the delivery model, but also for the people that are receiving them. And then finally, it's all about access and equity. If we get these services to people that already had access to them before, we haven't done ourselves any favors. We've just added a little frosting on the top rather than really recreated the entire system in a way that works for the most vulnerable among us. And so as we close out, I say this to my team all the time, that when we design systems where the science of public health, the passion and the motivation and the innovation of healthcare, and the supportive role of human services in meeting unmet social needs all are driving in the same direction together on this sort of 3-lane highway to health without any barriers between them, the sky is the limit. And the people that win are all of us. There's no one who's left out when all of these things work together. And the digital platform to make these things connected, I think, has been one of the biggest wins that we've seen across the so many tragedies of the COVID-19 pandemic. And maybe, just maybe, this tragic loss will have been somehow worth it. And we owe it to the people who have lost loved ones and all of the things that we have suffered over the last year and a half, that we take the wins and we build them out and we build something that we really can be proud of for the future. And I believe that telehealth for communities, not just in healthcare delivery, but across the entire spectrum of all of these lanes, is really one of the things that we can do to showcase what we were able to learn across this experiment of the last year and a half. And I know that those of you who are with us today have the expertise and have the know-how and have the drive and have the passion to be part of that solution for the future. Thank you again for the invitation to join you today. It is always my pleasure to engage with this group. Thank you for everything that you do. And come back from the end of this day energized with solutions for building out this highway to health together. Thank you so much.
Hey everyone, we're done a few minutes early on that, so we'll give you a few minutes to get a cup of coffee, and we will gather for our next panel, which will start at 9:15. Thanks.